The cervix is the lower cylindrical part of the uterus that opens into the vagina. Histologically, the cervix is different from the rest of the uterus and also has a mucosa that doesn't shed during menstruation. The cervical mucosa can be separated into three distinct regions: the endocervix, transformation zone, and ectocervix, which is also called the exocervix. The endocervical mucosa forms the wall of the cervical canal and will have a mucus-secreting simple columnar epithelium. The ectocervical mucosa is present in the part of the cervix that protrudes into the upper vagina and surrounds the external os, which is the lower opening of the uterus. This mucosa will have a non-keratinized stratified squamous epithelium that's continuous with the vagina. The transformation zone is the region between the endo and ectocervix. There's an abrupt change from columnar cells to squamous cells within the transformation zone called the squamo-columnar junction. The exact location of the squamo-columnar junction will change or shift depending on the age of the individual as well as changes in the size of the uterus during menstruation. The transformation zone is also the ideal site to collect cells from during a pap smear or pap test. Underneath all regions of the cervical mucosa is a thick cervical wall that consists of dense connective tissue. Unlike the uterus, it only has a small amount of smooth muscle present. The vagina connects the cervix to the external opening of the vagina called the vaginal vestibule. The wall of the vagina doesn't contain glands and is composed of three main layers: the inner mucosa, which is typically about 150 to 200 micrometers in adults, a muscular layer called the muscularis, and an adventitia of connective tissue. The adventitia also contains a large amount of elastic fibers, which allow the vaginal wall to be both strong and flexible, which is particularly beneficial during childbirth. Let's first take a closer look at the mucosa of the endocervix, which is continuous with the endometrium of the uterus and is lined with a similar epithelium of mucus-secreting simple columnar cells. Underlying the epithelium is a thick lamina propria, which contains the large, branched cervical glands that produce about 20 to 60 milligrams of cervical mucus per day. But during the time around ovulation, the increasing level of estrogen will cause the glands to produce significantly more cervical mucus, which can be as much as 600 milligrams per day. The consistency of the mucus will change as well and become watery. This allows the sperm to move more easily into the uterus. At the transformation zone, the simple columnar cells of the endocervical mucosa suddenly change to the stratified squamous cells of the ectocervical mucosa. Pap smears ideally include the transformation zone because cells in this zone are frequently undergoing metaplasia, changing from columnar cells to squamous cells. The frequent changing of cell type increases the chance of an abnormal change to occur, which can potentially be a precancerous change. Squamous cell carcinoma is the most common type of cervical cancer and is most often found in the transformation zone. Human papillomavirus, or HPV, is also a predisposing factor for squamous cell carcinoma, particularly the strains HPV-16 and HPV-18. The mucosa of the ectocervix is lined with the same non-keratinized stratified squamous epithelium that was seen in the transformation zone. The middle and surface layers of the vaginal epithelium store glycogen, which is released when the epithelial cells are shed or exfoliated. The normal bacteria found within the vagina will metabolize the glycogen and produce lactic acid, lowering the pH significantly, which helps inhibit the growth of many pathogenic microorganisms such as Gardnerella vaginalis and Trichomonas vaginalis. Cervical glands can be found in the lamina propria of the mucosa, but there are very few of these glands when compared to the endocervix. Alright, now let's move to the wall of the vagina. The vaginal wall is lined by the same type of stratified squamous epithelium that's seen in the ectocervix. Also similar to the ectocervix, the middle and surface layers of the epithelium store glycogen, which indirectly leads to a lower vaginal pH that helps inhibit the growth of pathogenic microorganisms. Underlying the vagina's mucosa is the supporting layer of dense, irregular connective tissue called the lamina propria. This layer is highly cellular and rich in both elastic fibers as well as collagen. The lamina propria also forms narrow projections or papillae that extend into the overlying epithelium. Also, unlike the cervix, there are no glands found within the lamina propria of the vagina. The next main layer of the vaginal wall is the muscularis, which consists of 2 layers of smooth muscle that are not clearly differentiated or defined. The inner layer is arranged circularly around the vaginal canal, and the thicker outer layer is arranged longitudinally. Just outside of the muscularis is the outermost layer of dense and loose connective tissue called the adventitia, but this layer is often not included in histologic images of the vaginal wall.
Now, let's get a closer look.
The internal female reproductive organs consist of the ovaries, fallopian tubes, uterus, and vagina. The fallopian tubes are also often called the uterine tubes or oviducts. These fibromuscular tubes transport a mature female reproductive cell or egg cell called an ovum from the ovary to the uterus. Each fallopian tube is about 10 to 12 centimeters in length and is divided into 4 regions. Closest to the ovaries is the infundibulum, which has finger-like projections called fimbriae. Next is the ampulla, then the isthmus, and finally the intramural part, which travels through the wall of the uterus in order to transport the ovum into either the upper left or right of the uterine cavity. The ampulla is the longest region, and fertilization of an ovum is most likely to occur in this region. The uterus is a hollow, pear-shaped muscular organ that nourishes and supports the growth of an embryo during pregnancy. The curved top or superior part of the uterus is called the fundus, the largest section in the middle is the body, and the bottom, more cylindrical portion is the cervix. Although the cervix is part of the uterus, it's histologically different from the rest of the uterus and will be covered in a separate video. This video will just focus on the fundus and body of the uterus, which consist of 3 major layers: the inner endometrium, myometrium, and outer perimetrium, although the perimetrium is too thin to easily see in this image. The endometrium is the inner mucosal layer that's lined with simple columnar cells. The myometrium is a thick and highly vascular wall of smooth muscle. And the perimetrium consists mostly of a serosal layer or visceral peritoneum that's continuous with the broad ligament, although there are portions of the uterus that are surrounded by an adventitial layer of connective tissue instead. Alright, let's first take a closer look at the fallopian tubes. The wall of each fallopian tube also consists of 3 main layers: an inner mucosa, a thick layer of smooth muscle called the muscularis, and a thin outer serosa. At low magnification, the outer serosa is difficult to see, but if we zoom in closer, we can see that this layer is composed of only a single layer of basophilic or purple simple cuboidal cells and a very thin layer of supporting connective tissue. The mucosa of the fallopian tubes have many long, thin, and branching folds, which mostly run longitudinally in the same direction as the tube itself. The mucosal folds are more prominent in the ampulla and gradually become smaller in the regions closer to the uterus, with the intramural part of the tube no longer having any mucosal folds at all. At high magnification, we can see that the mucosa is lined with a simple columnar epithelium. This epithelium actually consists of 2 distinct types of cells: ciliated cells and secretory peg cells. The ciliated cells can be identified by their visible cilia that wave or sweep fluid toward the uterus in order to help an ovum or fertilized zygote to continue moving in the correct direction within the fallopian tube. Also, the cytoplasm of the ciliated cells often don't stain as dark when compared to peg cells, making it slightly easier to distinguish the 2 types of cells. Each peg cell has an apical bulge that literally looks like a peg that's protruding into the lumen. These cells secrete a mucus that forms a film that covers the epithelium and provides nutrients for the ovum or fertilized zygote. Unlike many other tubular tissues, there are no goblet cells or glands in the mucosa of fallopian tubes. In this image of the muscularis, it's easier to identify the two layers of smooth muscle that make up this layer. Since this image is a cross-section of the fallopian tube, muscle fibers that are parallel to the plane of the cross-section will have a longer appearance. As a result, the inner interwoven circular or spiral layer of smooth muscle will have muscle fibers that look longer, and the outer longitudinal layer will have muscle fibers that look more round. The inner circular muscles have peristaltic or wave-like contractions that help physically move an ovum or fertilized zygote toward the uterus. Now, let's move to the uterus. In this cross-section of the uterus, we can see the clearly defined and basophilic endometrium and the surrounding myometrium. The endometrium is further divided into two zones. The functional layer is the upper or surface portion, and the basal layer is the underlying portion of the mucosa. The functional layer is the portion of the endometrium that's shed during menstruation and can be as much as 4 times thicker than the basal layer. The basal layer remains attached during menstruation and regenerates the functional layer. The functional layer's simple columnar epithelium consists of both ciliated cells and non-ciliated secretory cells. During the menstrual cycle, the epithelium invaginates to form simple tubular glands called uterine glands, although the glands contain fewer ciliated cells compared to the surface epithelium. These glands extend through the functional layer and form their base within the basal layer of the mucosa. The uterine glands produce a fluid rich in glycogen, which helps support the development of an embryo. The surrounding supportive tissue is the endometrial stroma, which contains an extensive microvasculature as well as a large number of cells, including stellate cells, macrophages, and lymphocytes. The myometrium is made up of 3 layers of smooth muscle. Although the individual layers are typically difficult to distinguish from one another in the uterus, the inner layer and outer layer consist mostly of longitudinal bundles of smooth muscle. The middle layer is the thickest and contains interwoven circular or spiral bundles of smooth muscle. This layer is also called stratum vasculare, since it's a very vascular layer with many large blood vessels that supply the endometrium. The blood supply of the endometrium is unique and also undergoes many changes throughout the menstrual cycle in order to accommodate the shedding or sloughing off of the functional layer of the endometrium. Arcuate arteries are the large arteries found in the middle layer of the myometrium. These arteries are branches of the uterine arteries and continue to branch further to become the radial arteries that extend into the endometrium. From here, the basal layer and functional layer actually have separate blood supplies, which is why the basal layer's blood supply is not dramatically affected when the functional layer loses blood during menstruation. The straight arteries supply the basal layer, and the spiral or coiled arteries pass through the basal layer but only supply the functional layer. The spiral arteries will branch further to become the arterioles and dilated terminal capillaries that form a rich superficial capillary bed. The distal portions of spiral arteries are sensitive to progesterone, so they'll rapidly grow as the functional layer thickens during the proliferative phase of the menstrual cycle. The functional layer of the endometrium undergoes some of the most significant changes throughout the 3 phases of the menstrual cycle. The change between each phase is gradual, but each phase will tend to have distinct characteristics that help differentiate it from the other phases. During the proliferative phase, the functional layer of the endometrium is regenerating after menstruation and is still relatively thin. The endometrial stroma is more cellular during the phase, and the uterine glands are relatively narrow and straight. During the secretory phase, the functional layer continues to regenerate, but also the uterine glands begin to accumulate and secrete glycogen, which causes dilation and eventually coiling of the glands. During the menstrual phase, if no embryo is attached to the endometrium, the functional layer sheds and passes out of the body as menstrual bleeding. By the end of the menstrual phase, the remaining endometrium is usually very thin before transitioning or cycling back to the proliferative phase.
Now, let's get a closer look.
The mammary glands of each breast consists of about 15 to 25 sections called lobes, with each lobe containing many smaller structures called lobules. Each lobule consists of a large number of alveolar glands, which are the small sac-like structures that produce milk. The milk produced by the alveolar glands drain into the terminal ducts that join together to form the intralobular ducts. These ducts converge further and form the lactiferous ducts, which drain the lobes and eventually lead to the nipple. All of the lobules and ducts are also surrounded by fibrofatty tissue that provide a supportive and protective function. Before pregnancy, the mammary glands are considered to be in a state of inactivity, and they're structurally different from mammary glands that are in the active state. The active state occurs during pregnancy and during lactation after childbirth. During pregnancy, the alveolar glands and the duct system will grow in preparation to produce milk for a newborn baby. This low power image is an example of lactating mammary glands in the active state. A portion of a lobe can be seen surrounded by a thick layer of connective tissue that contains a small number of fat cells or adipocytes within the connective tissue as well. Within the lobe, thinner layers of connective tissue separate the lobe into lobules. In a neighboring lobe, we can also see a couple of large lactiferous ducts. These ducts are lined with a double layer of columnar or cuboidal cells with a surrounding layer of connective tissue. If we take a closer look at one of the lobules, we can see some of the smaller intralobular ducts that are typically lined with 1 to 2 layers of cuboidal cells that also have a thin layer of connective tissue that surround the ducts. In this image of a different lobule, we can see a good example of a few alveoli and a longitudinal cross-section of the terminal duct that's responsible for draining the milk produced by these alveoli. Both the terminal ducts as well as the alveoli are lined with either cuboidal or columnar secretory cells. The supportive tissue between the ducts and alveoli is called the intralobular stroma. It consists mostly of loose connective tissue, but it also contains small blood vessels, fibroblasts, plasma cells, a few adipocytes, and myoepithelial cells. Although the wavy connective tissue can be easily seen in this image, some of the other structures can't be identified as easily, since the intralobular stroma is typically very thin and sparse in mammary glands that are in the active state. Now, if we compare mammary glands in the active state to an image of an inactive or resting mammary gland, the most significant difference seen histologically is the nearly complete absence of the milk-producing alveoli, which we can see even in these low-power images. As a result, the majority of the resting mammary glands consist of connective tissue and adipose tissue. The lactiferous ducts will still be present, but they'll typically be smaller and will often appear flattened or collapsed. But the lining of these ducts are still the same, with a double layer of columnar or cuboidal cells. The general structure of the terminal ductules are also still the same in resting mammary glands, with a simple cuboidal epithelium and a surrounding intralobular space that consists of connective tissue, fibroblasts, myoepithelial cells, and in this image, we can also see a small blood vessel present in the upper right. Myoepithelial cells surround the terminal ducts, but they also surround the lactiferous ducts and the alveoli. During breastfeeding, increased oxytocin will stimulate these smooth muscles to contract and lead to milk ejection from the nipple. The myoepithelial cells are typically located between the secretory cells and the basement membrane, so they are also an important histological marker for the presence and progression of primary breast carcinomas. As a breast tumor progresses, the reduction or disappearance of myoepithelial cells may suggest a transition to an infiltrating or invasive status. Alright, as a quick recap, the mammary glands consist of alveolar glands that are organized into lobules, along with the terminal and intralobular ducts that drain the alveoli. The active state starts during pregnancy when the lobules increase in both size and total number, and the alveolar glands become the most prominent structures in the breast. The inactive, or resting state, is when an adult female is not pregnant or breastfeeding. In this state, the ducts are smaller and the secretory alveoli are undeveloped. In both states, the alveoli and terminal ducts are lined with cuboidal or columnar secretory cells. The intralobular ducts will have 1 to 2 layers of cuboidal cells, and the lactiferous ducts will have 2 layers of columnar or cuboidal cells.
Now, let's get a closer look.
The internal female reproductive organs consist of the ovaries, uterine or fallopian tubes, uterus, and vagina. The ovaries are almond-shaped structures that produce steroid hormones like estrogen and progesterone, as well as the female gametes or oocytes. Each ovary is typically about 3 centimeters long, 1.5 centimeters wide, and 1 centimeter thick, with a thin outer capsule. The capsule is made up of a thin layer of simple cuboidal epithelium that's only 1 cell thick, and an underlying dense layer of connective tissue called the tunica albuginea. The majority of the ovary consists of the cortex, which is the outer region where the oocytes and ovarian follicles develop. Ovarian follicles are the fluid-filled structures that each contain an oocyte. The cortex of the ovary has highly cellular connective tissue in comparison to the inner region of the ovaries called the medulla, which consists mostly of loose fibroelastic connective tissue with many large tortuous blood vessels, lymphatic vessels, and nerve fibers. Alright, let's take a closer look at the cortex. The primordial follicles are the follicles found in the outer cortex that develop during fetal life. At this stage, they actually stop developing, which is called arrested development, and they stay this way until they're needed for ovulation. The primary oocyte is the large round cell that makes up the majority of each primordial follicle. The primary oocytes have a prominent nucleus and a diameter that's about 25 to 30 micrometers. The outermost layer of the primordial follicles is a single layer of flattened follicular cells, which are pregranulosa cells. The zona pellucida is a very thin, pink or eosinophilic layer of glycoproteins that sits between the primary oocyte and the outer follicular cells. When a primordial follicle continues developing, the next stage of follicular development is called the primary follicle. At this stage, the outer follicular cells from the primordial follicle have transformed into cuboidal granulosa cells. At first, the granulosa cells only form a single layer of cells, so these follicles are called unilaminar primary follicles. As the follicle size increases, the granulosa cells multiply and form multiple layers around the oocyte, making their name change to multilaminar primary follicles. At this stage, the eosinophilic zona pellucida is now more prominent and easier to identify, with multiple filaments that can be seen branching off the zona pellucida. The stromal cells that surround the follicle differentiate into a layer called the theca folliculi, or follicular theca. This layer of highly vascular connective tissue also contains cells with endocrine functions. The next stage of follicular development after the primary follicle is called the secondary or antral follicle. This stage can be identified by the formation of an antrum, which is a fluid-filled cavity that increases in size as the follicle matures and is formed within the granulosa layer. The granulosa cells will continue to proliferate and form a few structures like the corona radiata, which surrounds the zona pellucida and oocyte. The cumulus oophorus is also formed by granulosa cells, and it anchors the corona radiata, zona pellucida, and oocyte to the stratum granulosum. The stratum granulosum is the inner wall of the follicle that consists of the remaining granulosa cells. If we take a closer look at the follicular theca, we'll notice it's further divided into the theca interna, or inner theca, and the theca externa, or outer theca. The theca interna is more vascular and also consists of cells that secrete androstenedione, which is converted to estrogen by nearby granulosa cells. The theca externa is a more fibrous layer that also contains smooth muscle cells. The outer border of this layer will gradually merge with the surrounding stroma.